Okay. Same disclaimers as yesterday, nothing relevant to the presentation. I do want to start off by talking about the International Consortium for Evidence-Based Perfusion. And the reason I want to start this way is back in 2005, Al Stammers, as part of his strategic plan for his incumbent presidency years, was to try and encourage the development of the evidence base for perfusion and the participation in registries. And out of some initial meetings that Donnie Lukowski and I had with Al, the International Consortium for Evidence-Based Perfusion was born. And this was our mission statement. The ICEBP is a voluntary, multi-stakeholder collaboration that seeks to advance the delivery of care and outcomes for our patients. And I think what was particularly enlightening at the time was one of the ways we thought to act upon this with our vision was by trying to continuously improve the quality and safety of perfusion. And the way we were going to achieve that was by supporting the use of clinical registries dedicated to the evaluation of cardiovascular perfusion. Now, currently, to the best of my knowledge, there are 6 multi-centre, multinational registries currently operating. There's the NNE, there's the ANZ CPR, which is the registry from Australia and New Zealand. Sorry, the NNE is the Northern New England Collaborative Registry. There's the Perform Registry, which is the official registry of AMSECT. There's the Scope Registry, which is specialty care. There's JSECT, and there's the Core Registry. And I always get the C in help me out, someone quickly. CC? Comprehensive care. I always get it wrong. I'm so sorry. I had the card in my pocket just so I wouldn't get that wrong. So I reached out to these registries and asked them a few questions about 10 days ago, just to sort of give us some content for what we're going to talk about in the next few minutes. I asked them when the registry was started, how many centres currently contribute, what was the sort of approximate number of cases they had in their registries, what was their annual caseloads, what's their point of difference, what makes their registry something different and special. Did they have any comments regarding registries, and could they help me out had I actually missed any registries that I wasn't aware of? And so I was able to put together this little table, and you can see the NNE was the flagship registry for perfusion. It's a multidisciplinary registry. Started in '87, and many of you would be aware of some of the landmark work that came out of that collaborative registry. From a perfusion perspective, I think at the moment there's only 2 sites actually participating in the perfusion aspect of that registry. But it was very much a foundation upon which other registries leveraged, particularly Perform. In 2006, we started what was then called the Perfusion Down Under Collaborative Registry, which is now the ANZ CPR. We've had 11 centres. Our point of difference is that we've been able to harness the electronic data. So we have the continuous electronic data coming into our registry, and we have a link to our National Surgical Registry to allow us to have the outcome data. In 2010, the Perform Registry kicked off, and that's been very successful. It's got 47 centres, more than 120,000 cases. It's voluntary, and it links with the STS surgical data. Unfortunately, it doesn't have any access to electronic data at this point in time. Then there's the Scope Registry, the Specialty Care Registry, and that was started in 2011. That's had up to 300 different sites. Currently has about 200 sites participating in the registry. What's different about Scope? What's different about Scope is it's mandatory, and that's a really interesting sort of perspective on the whole ship. The participation in a mandatory registry, and part of being associated with a big company like that is it has a lot of support internally. And we have JSEC, and in some ways that's something the ICEVP can be very proud of, because it's really helped the Japanese society develop this registry over a number of years, and it's now just getting really good traction in Japan. You can see they've got 51 centres now contributing, more than 28,000 cases. And they're very much focused on measuring practice and quality improvement. And they're very proud of the fact that they've tailored that very much for their own market for Japan. And finally, we have the core registries, and they actually, Critical Care actually run 2 registries. One is using manually collected data, rather akin to the Perform style of data registry. And then their integrated database, which I think is what they're sort of more proud of, and really that's where the development's going to go in the future, is an integrated database that integrates the electronic medical record, has access to the electronic data, and produces some really excellent reporting back to the contributors. So you can see that we've got 6 registries currently. They're all slightly different, but that's what's serving our community at the moment. So collectively, we've got over 1 million cases in our perfusion registries at this point in time. So there's certainly a lot more that could be leveraged from this collective data than we're certainly doing at the moment. Now, I just want to talk about what registries are about. And the fine print on this, don't worry too much about, but it's talking about the science of clinical registries. Basically, it's saying that clinical quality registries can be a transformational tool to ameliorate healthcare delivery. And what they're talking about is how we can leverage data to improve everything we do in our clinical practices. They talk about some of their key principles, and these key principles don't change. There are important governance processes that must be adhered to. We have to be very clear in the data we're collecting and defining that data. It's important to embrace data management and training, not sort of try and push it to the side. It's a very important part of what we can do in registries. They're very important that there's a good level of quality control within registries. And probably, in my opinion, the keystone for registries is the reporting of outcomes and what they're doing. And it's this area that I think we see the biggest weakness in the perfusion registries that we currently have. That is the reporting back to the people who are participating in the registries. And that's not through lack of trying. I think largely it's a lack of resources on many occasions. But being able to allow people to benchmark their practices is really important. And I think that's something that the registries that we currently have could work a little bit together on to enhance. We report back with annual reports at the site level, at the group level, also with historic data, and we also do a report specifically tailored for management, such that the expectation is that every head of unit in cardiac surgery receives a report for their hospital, as does the senior administrator and the CEO of the hospital. And we report far too much in far too much detail. And that's a factor of immaturity. It's a factor of not being able to have enough feedback to say what people want to see at any point in time. And being flexible in reporting is difficult. It's all very time consuming. And certainly, accessing some of the newer products is where we need to go in terms of being able to present our data. The next 2 graphs are from the core registry, courtesy of Theorem Poor, who shared this with me. This is the ORM program. And it's just different ways of presenting data. And this is presenting data on the last 250 cases, and the percentage of cases that had a hemoglobin less than 7. In one of the graphs from my registry, there's similarly a metric of minimum hemoglobin during bypass. And they also bring this back to the perfusionist at the individual perfusionist level. And that's a really important aspect when we're trying to report information from registries. And as we heard from Martin in his awesome presentation earlier today, being able to get transparency at the individual level and at the hospital level is really important. This is a screenshot from the Scope registry. I apologise for the quality of the image, but basically it's a very encompassing all of service provision, and they have certain dashboards for perfusion, and here we can see oxygen delivery as one dashboard that they report. So how do we improve? What does the landscape of the future look like? Well, I think it's important that we embrace each other, become more collaborative, enhance the partnerships that we have with industry. We need to be working collaboratively and in partnership to ensure we do the best we probably can. Our registries need to be cloud-based. They need to adopt modern architecture in terms of their design. They need to be secure. The experience that we do have does need to be leveraged to ensure that we, as we heard from Bruce about perfusion education, we don't need to reinvent the stone. There's a lot of hard work's already been done, and we can benefit from that. It's absolutely essential that in that working with our corporate partners that we integrate electronic data on an absolutely seamless manner. We need to have real-time data sharing. We need to have consistency in what we're talking about, such that when I'm talking about a particular variable, it's the same variable that everyone else is talking about. Where are we up to? We need to take into account who we are. When you're behind the pump, there are lots of things going on. So there are a whole lot of human factors in that operating room that contribute to our work. There's the workflow that we do. So what our registries of the future have to do is harness your normal workflow to get as much information, as much data, as much constructive knowledge out of every case, but not by burdening the perfusion community with massive amount of work. We need to build ourselves for the future of machine learning and artificial intelligence. I can't imagine how much change we're going to see in the next 5 years just by being able to harness the data that we've already collected. We need to improve our reporting, as I said, with dashboards. We need to produce new knowledge. It's no good having all of this data if we're not producing new knowledge. And finally, it needs to be accessible. It needs to be available to every one of you, every perfusionist in all of our countries. But finally, and most importantly, we have to remember our patients and keep it patient-focused. So the value of registry. In 2018, I think it was, this was published in the Annals Circulation from the AHA and the thoracic surgeons. And it was a position paper on how evidence is rated. And the relevance to this presentation is that it was the first time that registry data was acknowledged as being really valuable in the hierarchy of data. And you can see that for a level A evidence level, we can use a randomised trial and registry data, good quality registry data. And the addition of this to our evidence base is really important, especially in perfusion, where randomised data is often really difficult for us to come to. I just want to give a recent example, and I mentioned this paper yesterday. This is the paper from the Perform registry, and it's some 40,000 cases, 18,000 Del Nido cases. And the reason I wanted to point it out to you, as I said yesterday, if we look at mortality, and we look at CABG mortality, and we look at renal failure, and we look at in the aortic surgical group, the authors suggested to us, that there's a potential risk of increased mortality in CABG patients, and there's a potential risk of increased AKI in aortic surgeries. We've got 1 million cases. We need to be reproducing that work and finding out if that signal's true and what we can do about it. Now, there's going to be lots of things you can't do with registry data at the moment. At the moment, everyone ticks the box for Del Nido, but we don't actually know what they're using. But, you know, it's the best we've got at the moment. So with that, on behalf of the adult registries, I'm going to pass over to Jim with Petty Perform after Richard introduces you.